this webinar, and I will actually talk about PRP, biological enhancement and acceleration of healing in shoulder and elbow surgery. Actually, just to give an overview and talk about where we're going. So this is my disclosures. I'm an advisor to Star Medical. So science facts or myths, and in recent years, the scientific literature as well as the newspapers and the media are exploding with publications regarding biological treatments. What is the science and what are myths? So the idea is in this presentation is to unveil the facts and the difficulties, to examine scientifically the biological treatments, to have better understanding for further improvements and to view for the future developments. So what is platelet-rich plasma? It's a fraction of autologous blood with a supraphysiological concentration of platelets. Upon activation, the platelet-derived alpha granules release autologous growth factors, and you can see the different growth factors here. And PRP is thought to promote physiological wound healing and rapid tissue regeneration. Are all the PRPs the same? No. And actually, not all PRPs are created equal. And let's see what is the ideal PRP formulation. So we're talking about platelet dose, platelet concentration, platelet yield, activation, yes or no, and if yes, how? Red blood cells concentration, leukocyte rich versus leukocyte poor. Again, this is not the whole picture. Which leukocytes, whether it's a mononuclease or the polymorphonuclease. Anticoagulant, yes or no, temperature. So the PRP healing process, actually, we have initially the signal of injury, then recruitment of mesenchymal cells, the migration of the mesenchymal stem cells to the injury, and differentiation of them to target tissue, and then proliferation of the mesenchymal stem cells or the progenital cells. And all that is coordinated by blood cells, and mainly the platelets play a primary role and influenced by other cells. So this is the wound healing cascade. We have the 3 phases. Initially the inflammation phase, then... Oh, come on. It's my phone, I'm sorry. So we have the 3 phases. First, the inflammation phase, then the cell proliferation and matrix deposition, which is, again, the starting of the healing phase, and then the matrix remodeling. And what we want to do is we want to jump over the inflammation phase straight into the cell proliferation and matrix depositing. So we want to cancel the inflammation. Therefore, we don't want the granulocyte and the phagocytosis, and we do want to have the macrophages and the cytokines to lead the second stage. So let's see what the red blood cells role in healing. So they do an hemostasis. They stimulate platelets to release thrombin. They cause inflammation because they release the macrophage inhibiting factor, which causes catabolism. And they stimulate the secretion of the pro-inflammatory cytokines, the MMPs, the interleukins, and interferons. Therefore, the red blood cells inhibit all other steps in the healing process. So what is the PRP composition? So we want to have a platelet concentration of 3 to 5 times or 2 to 5 times fold increase in platelet per volume of plasma. We want to control the volume, the PRP volume and the platelet concentration, and we want to adjust it to the clinical protocols. So if we use it for, let's say, lateral epicondylitis, we don't need a larger volume as we will need probably for impingement in the subacromial bursa. Again, white blood cells, as I said earlier, the polymorphonuclears, they are contribute to catabolic effect, but the mononuclears have the good cytokines that enhance anabolic and healing effect, and as well as they can help in fighting infection. The red blood cells, again, may decrease the cell proliferation and augment the apoptosis due to a cytotoxic effect, and they are catabolic as well. Activated PRP or not, again, it depends on the mechanisms of platelet activation. Exogenous substances may increase the risk of infections or allergic reactions. The best is the direct exposure to the collagen in situ, and the slower and the more sustained release of growth factors is compared with thrombid methods. Again, if you use it as the activation in situ, you eliminate the risk of immunologic reaction to exogenous materials and allergic reactions. So if we take different preparations of PRP, and this is actually what's available in the market, and I marked the proper cells with a red arrow. You can see that this is the rank by the contamination with red blood cells, and as you can see, it's actually in the tropo cells is 0. There's no red blood cells at all. Again, if we look rank it by the neutrophil contamination, again in tropo cells, it is really, really low. This is a study that was done independently by other group, and it shows a 4.3% of neutrophils, nearly 0. Again, when we talk about leukocytes, we have to discriminate between the mononuclears and the granulocytes or the polymorphonuclears. The polymorphonuclears, they actually aim to fight the intruder. They want to destroy the enemy, so they are catabolistic cells, and they cause inflammation. The monocytes and the lymphocytes, which are the mononuclears, they are the cleanup, so they do the recruitment, the migration, differentiation, and proliferations of the mesenchymal stem cells. So this is from a study by Kohida, and you can see they compared different preparations of PRP, and you can see the platelet concentration is quite high for the tropo cells. It's called micelles here, but it's the same preparation. The red blood cells is nearly 0, and the mononuclears are there, so there's no polymorphonuclears there. So what is a poor quality PRP? A poor quality is that is not enough platelets, that too many red blood cells, too many neutrophils, polymorphonuclears, and not enough mononuclear cells, and this causes a low anabolic catabolic ratio. So actually, it's more catabolic than anabolic. So to maximize the anabolic catabolic ratio, we need to have cells that promote anabolism, like monocytes, lymphocytes, and minimize the cells that promote catabolism, like the red blood cells and the neutrophils. So we can see here in this table, the same paper, the AC ratio, the anabolic catabolic ratio, and you can see the tropo cells is high up in the table, with the rest of them far below. I mean, most of them are not anabolic. That's 89% AC ratio for the tropo cells, and the rest are much lower. And that's where the problem lies. When we talk about PRP, every PRP is different, and we have to look at what is the composition of the PRP, and again, what is the AC ratio of that particular PRP. So are we there yet? Again, you tell me. But if we take what's the ideal PRP, so we want 99% platelets, we don't want any red blood cells, so 0. We want very little white blood cells, so we don't want any neutrophils, 0, but we want lymphocytes and monocytes. And you can see the comparison of the ideal PRP with what we get in the tropo cells PRP. So if you ask me, we are nearly there. I mean, or we are there. I mean, it's very, very close to the ideal PRP. You can administer the PRP in different ways, as a fluid, as a pure PRP, or with some exogenous substances, with local anesthetics, with collagen, as PRF clots, and with collagen. So different ways to administer it. What's important is to stop the use of non-steroidal anti-inflammatories at least 7 to 10 days prior to the PRP treatment, because they affect the platelets. So you need to stop them 7 to 10 days before you take the blood, and you have to avoid them, tell the patient to avoid them for at least 6 weeks after PRP treatment, because they contradict the effect of the PRP. The applications in shoulder and elbow are numerous. I mean, there's in the elbow epicondylitis, either the lateral epicondylitis or the medial epicondylitis, the tennis elbow and the golfer's elbow, the shoulder subacromial impingement, especially in patients with contraindication for surgery, like patients post-polio or with comorbidities that surgery is not is contraindicated for them. The injection of PRP can give them the relief they need. In rotator cuff tears and with rotator cuff tears and repairs, and I'll show you in a minute as well, shoulder osteoarthritis and osteochondral lesions, together with a microfracture or CAM procedure, and reconstruction of ligaments like the AC joint reconstruction or the sternoclavicular joint reconstruction. So for the elbow epicondylitis, we are going to use PRP. We take about 3 milliliters of PRP out of 20 milliliters of blood. We mix it with marcaine, with local anesthetic, and we do the injection. We do like a salt and pepper needling with the injection with the PRP. And we can see that from different studies, it's quite agreed now that PRP works well for tennis elbow or golfer's elbow. And in my experience, it works in 90% of the cases. I must say that in the last over a decade that I'm using the Tropocells PRP, I had to operate for lateral or medial epicondylitis. Very, very few cases I can count them on one hand. So really, the majority are working very well with PRP. Having said that, sometimes I have to repeat the injections, up to 3 injections in separate times to get the epicondylitis settled. But the majority, 1 injection would be enough. Rotator cuff tears, as you can see here, that's another indication. And we know that although we had a lot of improvements in understanding the rotator cuff disease and advances in surgical treatment and instrumentation, and we understand the biomechanical repair construct and all that, we still have high rate of re-tear. And we need to think how to address that. And to improve that, we have to talk biology. It's biology. And what we can use here is the growth factors. We can use cells like stem cells, tenocytes, fibroblasts, or we can use biological scaffolds like either biological or artificial scaffold to repair the cuff or augment the repair of the cuff. So when we do the arthroscopic repair, after we finish the repair, we put the needle into the footprint. We take all the fluid out. I ask my assistant to put fingers on the portals, and we inject the PRP with air, as you can see here at the bottom. And we wait a few minutes until it settles. And that's the way we do the autologous PRP injection at the end of the arthroscopic rotator cuff repair. What we've seen in a study that we've done quite some time ago is that the injection of PRP, the addition of PRP to the repair, and you can see this lady here 6 months after repair of a massive rotator cuff tear and PRP, and she is delighted. And what we've seen is that it really helped with the pain control after rotator cuff repair. Rotator cuff repair is notoriously a very painful operation. And since we've been using the PRP, we've seen in this group that more than 93% of the patients that had PRP had minimal amount of pain immediately after surgery. They stopped taking painkillers or took only the occasional painkiller at 3 weeks post-surgery. This is compared to the group that was the control group that was a historical control prior to the use of PRP, that it's the same operations, the same surgeons, the same techniques, but in this group, 57% of these patients were still on heavy painkillers at 3 weeks or even more after surgery. So we've seen in this study that the autologous PRP injection, and again, we're talking about troponin cells, after rotator cuff repair improves significantly the early postoperative pain. The situation at 3 months and 6 months was slightly better if you look at the constant score. However, there was no significant difference in function and pain at the later stage. So maybe there was a trend of improvement or of the constant score, but overall, all of them were good. So maybe if it was a bigger group, we would have seen some difference, but at least the pain control immediately after surgery is outstanding. And the patients are really thrilled about it. We've seen that this is the same finding of my good friend Pietro Randelli in his study with platelet-rich plasma in rotator cuff repair, and he found the same. That the pain control was much better. The long-term results were suggested slightly improving with the PRP, but again, very similar. 2 different studies and actually 2 different PRP compositions, but gave the same result. And we can see that it's actually in some other studies, but unfortunately, again, the composition of the PRPs are different, and therefore some studies showed different results.
Hi, I'm Harriet. Prior to Professor Levy doing a rotator cuff repair, I didn't sleep for about 1.5 years. I'm a sport man. I play golf all the time, squash, tennis, and it was making my life really awful. Since I had the operation, it has been a huge success. I am a new person. It's a year on. I can do everything. I can lift my arms. I can swing. I can even do a topspin tennis serve. I'm very happy. My golf swing is hugely improved. And I'm just invigorated now for life. I'm just very happy. I run all the time. I do 3 lots of 5K a week running. And I'm just so pleased I had this operation. It's changed my life, and I'm very excited for what's ahead. Thank you.
So this is one of the patients that you can see that was treated with rotator cuff repair and PRP. Now, what do we do with case like this? This guy has got massive irreparable rotator cuff tear. You can see he's got escape, anterior superior escape. You look at you see in the arthroscopy, he's got nothing left, actually almost nothing. And to tell the truth, I thought that this will not work, but he persuaded me that I need to try to do a repair. So what I did in this case, I did a repair with a scaffold, with a patch. I used this synthetic patch, and this patch got good initial strength and resistance to suture cutout. And again, it's biologically friendly, so it actually friendly to cells. The cells can actually grow into the woven patch. Here's the surgery. You see, that's actually nothing left from the cuff. It's just a remnant of the rotator cuff. So we try to reduce the size of the tear as much as we can. We do the preparation, the release, try to repair as much as you can. So we do a partial repair, as you can see here, and after that Again, this is the part of the partial repair. This is arthroscopic repair of the rotator cuff, and then we put the patch in. We spread the patch on the rotator cuff and to cover the gap, so we augment and bridge the gap. We fix it medially to the, as you can see here, to the muscular tendon junction, and then we repair it distally to an anchor, and at the end we actually put the needle into the patch, take all the fluid out, and inject the PRP with some air, as you can see here, and the PRP actually is covering both the patch and under the patch into the footprint. In this group, we had 30 patients, mean age 60, and we treated them with that. Again, the constant score has improved was initially 36, and the mean preoperative elevation was 108, and then you can see the constant score has improved to 74.5. The age and sex adjusted was 100. This was between 14 months to 8 years follow-up. Look at the video that you see at the top. This is an ultrasound, and you can see the patch in the middle, which created a nice thickness of tissue there. And obviously, most of these patients were very satisfied. The mean final elevation was 167. 3 patients actually had to be revised to a reverse shoulder, and this was because the muscle has died. I mean, they didn't have any more muscle to pull, and that's why it's that the patch didn't fail. But this gave us the chance to look at them. So this is one of the cases. This is the case that we've seen initially. You remember this guy with this massive tear. This is 6 months after surgery. You can see his function. It's really unbelievable. And you can see in the MRI here, he's got something at the top, which is the patch that we did with the new tissue formation with a PRP. These are the results, and you can see the improvement and actually the final results. And oops, sorry. So this is one of the cases that we had to revise, and you can see that this is the patch, and this is a new tendon. A new tendon was born there. So this didn't fail. What failed was the muscle that couldn't pull anymore. So the engine has gone. And this gentleman, again, it's 5 years down the line after repair of this massive cuff tear with a patch and PRP, the Tropocells PRP. This is the ultrasound you can see as well. This is the patch in the middle, the white bit, and you see the thickness of the new tissue. So actually it regenerated a new tissue. I'm not sure this is the quality of a real tendon, but it works well, and as you can see here. So this lovely lady has got had poliomyelitis in her childhood, and she's using crutches and braces to walk. Again, she had bilateral massive cuff tear. On one side, I did a rotator cuff repair and PRP, but she had to be on a wheelchair for 6 months. And when it happened on the other side, she didn't want to be another 6 months in a wheelchair, and therefore I injected her with only PRP. And she is now, I think she's 10 years down the line. She is delighted, as you can see, and this worked well. I don't think it's repaired anything, but it certainly helped her to oops. So what happened here? Sorry, it actually pushed me out. So, so you saw this lady; she's very happy. So, in these cases that I don't want to operate for any reason, I use PRP for their symptoms. Another thing is the AC joint dislocation and the reconstruction of the AC and the CC ligaments. Again, we're using the PRP, as you can see here. We use this a ligament scaffold, we use a PDS cord, and we use the PRP. And you can see here how we do that. And we have excellent results with that for quite a long time now. We are due to publish our results with a large number of patients that we use this technique. Another reconstruction is the sternoclavicular joint, and you can see this lovely lady that she's a horse rider. She fell off her horse, she dislocated the sternoclavicular joint, and this is popping in and out all the time. We stabilize it in a similar technique with a scaffold, a synthetic scaffold, and a PDS cord and PRP. And this is this lady actually with no recurrence, with good stability, and very, very pleased. Another thing is the use of PRP for osteoarthritis, and we know that in the knee it's been used quite a while for knee osteoarthritis. We've been using it now for the shoulder as well, and we do arthroscopic release, microfracture, and we inject the PRP. As you can, oops, sorry. And you can see here we inject the PRP. And this young gentleman is, after this treatment, actually regained full function. And we may, again, not in all the cases, I would say about 70 to 80% of the cases, we may delay the need for shoulder replacement by doing this CAM procedure with microfracture and PRP. Again, you can see this is a study that we've done. Again, this gentleman, again, a year after this CAM procedure and PRP, and you can see overall the results in the graphs on the right side. Another lady that had severe arthritis, and we did the same, and you can see the results. And this result actually shows that we have about 80% success with this, and it's similar to other series by Millet and Van Thiel that had, again, about 20% of failures. Future, again, this is another thing that with ASTAR we are examining. It's the use of recombinant collagen. This is a collagen made of tobacco leaves. And we did some studies together between the two companies and showing that the use of collagen, which is human collagen, type 1 collagen made from tobacco leaves, together with the PRP, the tropa cells, works extremely well, both in animals and in tennicellular in humans. So where are we going? Again, as Einstein said, imagination is more important than knowledge to forecast the future. And I'm happy to answer any questions you have. Thank you very much.
So thank you, Professor Levy, for this amazing session. We have two questions in the Q&A box. First question. Any protocol changes for patients on long-term anticoagulants?
Yes, I mean, again, it depends on which anticoagulants, and if the anticoagulants actually affect the platelets, I would actually see if I can. I mean, sometimes we probably can't use it. But if they affect the platelets, I would see if we can stop them for a week, because you want the platelets to be in the best capacity. And if not, maybe these are the cases that we are, relative contraindicated for the use of PRP, because we may use it, but it may not work for the best. Yeah.
Thank you. Second questions. Any concern in PRP promoting adhesive capsulitis in an RCR?
No, to be honest, no. I don't remember any of the cases that we had, but Obviously, if there's overshoot of the healing, it may cause some stiffness. But again, I'm less concerned about stiffness because we know how to treat stiffness. We don't know how to treat non-healing. And I prefer that we will have a healing, and then maybe if we need to. But I don't remember that the PRP caused any adhesive capsulitis or stiffness after the repair. More than without, it's not causing anything. Yeah.
Thank you. Another question: is PRP effective in RC tendinopathy in patients not eligible for surgery?
Definitely, that's what I said. Definitely, yes. I used it in patients that are not eligible for surgery with good results. I think that in a way, we have a problem because the NHS and the insurance companies are not funding PRP yet. And the problem is that, as we said initially, that not all the PRPs are the same. So you have papers that shows the PRP works brilliantly. You have papers that shows that PRP doesn't work. If you look at the details, obviously you'll see why they didn't work. And because of that, obviously, governments and insurance companies will jump on the fact that, oh, it doesn't work, we are not going to pay for it. So if they're not paying for it, you can't do it for all the population. What we do, we offer the PRP as a private procedure. And if the patient wants to have it as a private procedure, that's fine. So I offer it, and actually today I did about 3 PRP injections to patients that wanted to defer surgery and to see if the PRP works. And obviously I've done it, and hopefully this will work for them. Definitely, that's something that we have to use. Again, hopefully in the future, hopefully we will do some studies that will show that PRP, and people will stop talking about PRP, but we'll talk about which PRP they're using, and they will approve certain PRPs to be used, both in the NHS and the insurance companies. Yeah.
Thank you. We have 2 more questions. How many times would you advise to repeat PRP before you decide whether it is helping the patient?
I would again. It's there's no science here. We don't know, but I feel that 3 times is about right, and so I will give the PRP. I will wait 4 to 6 weeks. Usually there will be some improvement, but not complete. Then I'll give another one, wait another 4 to 6 weeks, and then give a third one. And if after 3 injections it didn't work, then we say, well, it didn't work. But usually it works. It works in the first one, usually, and some will have to give the second and the third. Yeah.
Great. Another question. Please describe the application of the PRP into the RC again.
Pardon? I didn't know.
Please describe the application of the PRP into the rotator cuff again.
During the repair. Yeah. So we finished the repair, the construct. I put the scope back in the bursa after I examined that the repair is intact both in the joint and in the bursa. I then look in the bursa. I take a needle, quite a large bore needle. So I use the Venflon 14 gauge, which is the gray Venflon needle. It's quite large, and I go into the bursa from the skin, and I put it in the area of the repair just towards the footprint where I repaired. So I go through the tendon into the area of the footprint. Then I take the PRP. I take it in a syringe, a 20 ml syringe, which I usually use 3 mils of PRP out of 20 mils of blood. And I fill the rest of the 20 mils, so 17 mils of air. So I take 3 mils of PRP and 17 mils of air. I, at that stage, stop the inflow of fluid and squeeze the shoulder from the rest of the fluid out. At that stage, ask my assistant to put his fingers or her fingers on the portals to be the little Dutch boy or girl to put the finger in the hole in the dike and stop any extravasation later on of the PRP. And then I inject through the needle the PRP with the air, and that's how you can see it. I can actually go back to I'll show you just a second. I'll show the way I do it. Okay. So you can see here at the bottom, I finished the repair. I put the needle into the footprint. Now I'll take all the fluid out, and you can see all the blood is coming because the fluid out. Put the fingers and then inject the PRP with the air. Can you see that?
Yeah.
And that's the way I put it. So part of the PRP will go under the repair into the footprint, and part will come on the top. So it's all covered with PRP.
Great. We have several other questions. What advice will you give if patient is on warfarin or other anticoagulants?
The platelets, I mean, the warfarin actually works differently from the non-steroidal. So I will probably use the PRP as normal. I wouldn't stop it, and I use it as normal. When you inject it, you have to make sure that you inject it and not causing too much bleeding. So if you inject it into the bursa, that's fine. If you inject it intraoperatively, it's fine. Usually, if someone is on warfarin, he will be on low INR during surgery. So I can't give you an overwhelming advice, but yes, I mean, use the common sense, but you can use the PRP. There's definitely can use the PRP.
Thank you. Another question, is it better to give PRP ultrasound guided?
Well, the ultrasound guided is a bit of a gimmick. If you know where you are, you don't need the ultrasound. You can get to the bursa without ultrasound. If you don't know where you are and you need the ultrasound to get in, use the ultrasound. You can use it either with ultrasound or without ultrasound. If you're in the right place, it doesn't matter if you use ultrasound or not. Each surgeon actually can use his own capabilities, whether you want to use ultrasound or not. The downside of ultrasound is the fact that you are messing with something in the area of the injection, and you may introduce risk of infection. The advantage of the ultrasound that you know exactly where you are, even if you don't really 100% sure about the anatomy of where the needle is going. So it's the preference of the surgeon. Yeah.
Great. Any experience in using BMA or associated stem cells in association with PRP?
Not on this stage. We are thinking about it. We are there's a lot of thoughts about this, but I haven't used it yet in a way that I can give any advice. Yeah.
Great. Last question. Do you prefer with or without lidocaine? Recommended ratio between lidocaine and PRP?
I use with lidocaine. We did studies in many years ago when we started. More than 12 years ago, we did some studies to see if the lidocaine affects the growth factors and the platelets, and actually there was no effect whatsoever. So we're using it with lidocaine. I must tell you that one of my fellows once did it without lidocaine. It ended up with a patient that went to litigate because of the pain. It was so painful. So I mean, you must use some pain, some local anesthetics. Some people put the local before, but then I don't see the advantage of that. I mix them together, and usually what I do is I use, let's say for lateral epicondylitis, I use the 3 mL of PRP and 2 more mL of lidocaine or marcaine and inject them together. If I use it for the impingement, I use a larger volume of local anesthetic. So I use altogether, it will be 10 mils altogether, 3 mils of the PRP and 7 mils of Marcaine. And when I use it for rotator cuff repair, I use it pure PRP with air, with nothing else, because the patient is already anesthetized and it's got an interscalene block, so I don't need any painkillers for that. Yeah.
Wonderful. We don't have any more questions, so I would like to thank Professor Ofer Levy for this amazing session. Thank you for your time. I really appreciate it. It has been interesting, and thank you for sharing your knowledge with us. And I would like to thank all the people who attended this talk, and we will, of course, let you know our next educational session. We're trying to do it on a monthly basis for a variety of medical applications, and we will, of course, share the new ones when it's relevant. In the meantime, thank you again for joining us. And I hope you enjoy your weekend. And thanks again for Professor Ofer Levy for this amazing drill. Thank you very much.
Thank you very much. And everyone, if anyone wants, welcome to join Reading or to contact me. I'll be happy to give advice. Thank you, Yuval. Thank you very much.
Thank you. Bye-bye. Bye, everyone.
Bye. Bye.